Our next section is on anatomy, and we're going to take a look here at critical aspects of anatomy that I think every emergency physician should be aware of, including head and neck and jaw positioning, the fact that the epiglottis is the center of the airway. We're going to discuss the intricacies of the laryngeal inlet and laryngeal landmarks, as well as some surgical anatomy as well. Mouth opening, the dental arch, the tongue, and epiglottis all affect laryngeal exposure. The trachea itself is a narrow corrugated tube, approximately 11 centimeters in length, with a diameter of only 15 to 21 millimeters, and it follows the thoracic spine into the thorax, so it goes posteriorly. And understanding anatomy well is really important for physicians when it comes to improving laryngeal exposure, as well as recognizing landmarks and tube delivery. Everybody in respiratory distress puts themselves in a head forward position. And what I mean by that is their head is forward relative to their chest. I came up with this line I call the ear to sternal notch line, that when we intubate and when we're doing airway procedures, we want the head forward relative to the chest until the external auditory meatus is lined up with the sternal notch. And on the left here, we have a picture showing how with the head inclined forward, with the head forward relative to the chest, that's the position we want. This neutral position, where the chin is back like this, as you would have a patient flat on their back or on a board, is not ideal for airway management, and nor is atlanto-occipital extension. So if you want to swallow a sword, this is a good position to be in, but for the purposes of intubation, head forward positioning. These images are actually done are pictures of me with a tracheal tube in place. So I put a tube in my nose, walked over to radiology, and I shot these pictures. But the reason why head forward positioning is so important is because you can see it maximizes upper airway volume. So that space behind the tongue, base of tongue, to the posterior pharyngeal wall is maximized in head forward positioning. And atlanto-occipital extension actually decreases that, and it creates this double S or rather an S curve. So head forward positioning is best for laryngeal exposure. It's best for mouth opening. It's going to be best for intubation, whether that's direct or video laryngoscopy. Here's a picture actually of my son when he was a teenager, and it shows the effect of head positioning on mouth opening. So when your head is back, like so, your jaw is restricted in its movement, and you don't open very much. When your head is forward, your jaw can open much better. So with this ear to sternal notch aligned, head forward relative to chest, this line is strongly inclined forward, but that's the cervical spine going into the thoracic spine, and mouth opening is improved dramatically. So head forward positioning or head elevated positioning in a supine orientation improves both mouth opening and alignment of the cervical spine, so it matches the alignment of the thoracic spine, which is beneficial for tube insertion. This next slide shows fluoroscopy, which is dynamic X-ray of head and neck positioning, and as well as the chin. And in the top left here, you can see when I'm swallowing with my chin down how small the space is. But when my chin comes way forward and I lean forward, I'm pulling the base of the jaw, the tongue, and the epiglottis. Everything is moving forward, and we increase the space dramatically. So here's chin down swallowing, and then here's tilting up slightly. But look what happens when we lean forward. We open up that space dramatically. And by the way, some of the landmarks here to look at, this is the hyoid. Over here is the hyoid. Here's the epiglottis. Here's the vallecula. Here's the larynx. And these are just still images from that fluoro image. But it's rather dramatic how much head forward positioning improves upper airway volume, and that's why patients do it. Now, when patients are in a supine orientation, we're using a laryngoscope basically to drag the base of the tongue, the jaw, upwards and drag that tissue and open up space. This is a fluoroscopy courtesy of a friend of mine, George Kovac, up in Dalhousie and Adam Law, and they've done these wonderful fluoro images, and they're showing you what jaw distraction by pulling on the mandible or pushing up on the mandible in a supine orientation does. And conversely, tilting the head back does not open the airway. So we're going to take a look here at this dynamically, and you can see here as we tilt, there's the jaw popping, and you can see how much space there is. And when we tilt the head backwards, it doesn't open up the space. So this is chin lift there, which does minimal. Head tilt does nothing to open up that base of tongue and epiglottis. But when they pop the jaw forward, you can see how much space that creates. So remember when we were talking about opening the upper airway with oxygen on, pull the mandible forward, sit the patient up? Distraction of the jaw, what it's doing, in this case, pushing the jaw upward, is you're taking base of tongue and epiglottis with it, and you're bringing it off that posterior pharyngeal wall, opening up space. Here we have an image of CAT scan showing you these two curves of the upper airway in a supine-oriented patient. So we've got one curve that takes us around the curvature of the tongue, and we have another curve that goes around from the larynx and down into the trachea. And when we use video laryngoscopy, what we're doing is we're using a curved device to get around the curve with video, but then we have to go up in terms of inserting the tube into the larynx, and then we have to drop it down into the trachea. So you have these two curves, one around the tongue, and then one where the larynx is and it goes down to the trachea. And by the way, at the center of these two curves, the center of the world when it comes to the airway, halfway from where we're going at the mouth to where we're aiming at the larynx, at the center of this whole airway, midway between right and left, but at the center of these two curves is the most important upper airway structure when it comes to anatomy of the airway, and that is the epiglottis. So the internal landmark to be focused on when it comes to doing direct laryngoscopy, as well as endoscopy, is always the epiglottis, because it's the base of the tongue and it's the top of the larynx. But so here we have the vallecula, here's the posterior cartilages, here's the laryngeal cartilages, and going into the trachea, which is about 10 to 12 centimeters, and we have the corrugated rings. And notice how the trachea is following the thoracic spine. As it descends, it declines into the thorax. On CAT scan, you can look at the various planes, and I find in this sagittal plane, going back and forth on CAT scan is really useful to learn upper airway anatomy, and especially as it relates to surgical airway, but also for just in general understanding the relationship of structures. So we've got base of tongue, we have the vallecula, we have the epiglottis. It comes down into the larynx here. This is the partially calcified thyroid in this 35-year-old-ish man. Here's the cricoid, and that right there is the cricothyroid membrane. Here is the high back wall of the cricoid, and this is the smaller front ring of the cricoid. So CAT scan is fantastic for understanding the relationship of these laryngeal cartilages. In this view in sagittal, we can see where the tip of our curved blades are going to sit. So video or direct laryngoscope blades fit here. Here's our epiglottis, and then down here are laryngeal cartilages. And again, the trachea is moving posteriorly down into the thorax. I'm sorry, I said 35, but there's a 45-year-old, and the thyroid is already calcified. In younger people, the laryngeal cartilages are not evidently calcified, but this is a great example here. And I'm going to focus on one point, and it's clearly a male. You can see the prominence of the Adam's apple, but I'm going to leave my pointer right there to show you that where the thyroid is. So there's the front of the thyroid. And let's go to the front of the cricoid, and you see how small the front of the cricoid ring is. But then if we go to the back of the cricoid, look at how tall the back of the cricoid cartilage is. And then this view here, as we look posteriorly, we're going to see the thyroid horns come down inferiorly and superiorly. I'm going to hold it right here for a second. We're going to see the superior cornu of the thyroid going up to the hyoid. So I'm leaving the pointer right there, and right there is the top of the thyroid coming up to the hyoid. And so I find this CAT scanning is really useful to sort of 3D appreciate the upper airway. So I've taken now a coronal image of CAT scanning of the upper airway and put it side by side with a sagittal view. So the coronal view, here's the epiglottis sort of en face, and so here's the coronal view looking at the face of the epiglottis here. Here's the piriform, so dropping down alongside, outside of the laryngeal inlet is this blind sinus, the piriform sinus. We go from the false vocal cords, posterior cartilages here, down to the true cords down there, and here's the trachea. We have the cricoid down below and the thyroid above. So here's the correlation of the thyroid, and here's the cricoid down low. Here's the vallecula here, and the epiglottis tip. And just to show you, going a little further back in the neck, looking at coronal, what happens with hyoid, thyroid, and cricoid, where my elbows are, this is a rhomboid set of structures. So we've got the hyoid, we've got the superior cornu of the thyroid going all the way up to the hyoid, and then we have the inferior cornu of the thyroid, and it is overlapping the cricoid on either side. And when we get to the surgical airway, that's very important to appreciate, because we are going to cut at this level, and we drag our knife to the edge of the cricothyroid membrane, and we're blocked by the thyroid cricoid overlap. So if we're at the right place, if we're at the CTM, the cricothyroid membrane, we make our incision, we bring our knife over to the edge, the thyroid overlaps the cricoid, it's a hard stop, we flip the knife, we go in the other direction, there's a hard stop in that direction. And that's one of the reasons why that and the high back wall of the cricoid cartilage, I call this the cartilaginous cage, but it's a sort of a protected space in terms of us using a knife to open up the airway, because we have a hard stop on either side and we have a hard stop posteriorly. But it is interesting to appreciate in this view how the thyroid, when it comes to surgical anatomy, is the center of everything, because it spans from the hyoid, overlaps the cricoid, and it is the base of the thyroid where it meets the cricoid, where our cricothyroid membrane and our surgical airway will be. So internally, the center of the world is the epiglottis. Externally, in the surgical airway, the center of the world is the thyroid cartilage. Let's take a look at nasoendoscopy. We've got here some imaging of myself with an endoscope in place, and I am correlating it to an anatomic drawing from Gray's Anatomy that goes way back. But what we're looking at here is the entrance just right at the tip of the nair, and we're seeing medially, so we're looking at the left side of the patient from the center, and as we face the patient's left is to the right side of our screen. So coming laterally, coming from the side, is the inferior turbinate, and we're seeing that here and here. And then as we work our way down, we pass below the inferior turbinate. Again, the septum or midline is on the right side of our screen. Here's the septum. And then we get to the exit of the inferior turbinate, and we can see it here. Here's the septum. And we begin to see past the exit point of the nasopharynx. And that little recess is the eustachian tube, which correlates here. And we're seeing that right there. And then we come around the curve and we point the scope down, and now we are looking down towards the larynx, looking at the epiglottis edge and the uvula. So I find when we get to talking about nasoendoscopy, a lot of clinicians don't appreciate this upper airway anatomy, that it's critical. We're driving endoscopes as well as NG tubes medially along the floor of the nasopharynx, trying not to hit the inferior turbinate. So we always go into this space when we're driving scopes or NG tubes. And we do that by making sure we enter at 90 degrees, we go straight back, and we drive it medially along the septum. And then we have to make this downturn at the end of the nasopharynx. But we will discuss the subtleties of driving endoscopes in a subsequent lecture. I just thought it's really neat to look at the endoscopic views correlating with our drawings in this picture. When we get to the larynx itself, there's a lot of subtlety to these different landmarks that you don't appreciate when you see a flat two-dimensional view. So the laryngeal inlet is a ring of structures that I have marked in black that includes the epiglottis. It comes down to the aryepiglottic folds on either side, goes to the posterior cartilages, also called the arytenoids, but cuneiform corniculate, the interarytenoid notch, which during relaxation is wide, but in phonation closes. But we've got the interarytenoid notch, and then we've got the corniculate cuneiform on this side, the arytenoids back to the epiglottis. The false chords and the true chords I never understood until I started doing a lot of endoscopy work. But basically, this is a mucosal fold that is above and lateral to the true chords, which are the vocal ligaments. And during endoscopy, we're going to see this dynamically, which I'm going to show you in these next few slides. Here is a windowed view on a cadaver of upper airway anatomy after making an incision across the base of the oropharynx, hypopharynx, and we've got the hyoid. And remember, the hyoid kind of comes around, and the hyoid is the base of the epiglottis. So the hyoid, here's the tip of it, but the base of the hyoid, or the part of the hyoid ring, is going to be down low, and it goes from here up to there. But the epiglottis is suspended to the hyoid through the hyoepiglottic ligament. But here is the vallecula. So we've got hyoid, epiglottis edge, the vallecula, the aryepiglottic folds coming down on either side, and the vocal cords are down and deep and within this space that is down here. So we have posterior cartilages and larynx, and this is esophagus going here. Notice in this windowed view of the airway how high up the epiglottis is. So we come down the curvature of the tongue, we get to the vallecula and epiglottis, but the actual vocal cords are down here. So here's the tip of the epiglottis, and here's where the actual vocal cords are, deep within the laryngeal inlet. And I've marked down below here, obviously this is anterior, that's posterior. These are wonderful old images through drawings made by J. Solis Cohen. J. Solis Cohen, one of 5 brothers who served in the Union Army, he and his 5 brothers, all physicians, served in the Union Army. But after the war in 1869, he went off to London, and he studied with a guy named Morrell Mackenzie. And he was doing work with mirrors looking at the larynx, and they first started describing the anatomy of the larynx. And what I love about these old pictures This is a view on the left of the larynx when it's relaxed, breathing, and on the right is with phonation. But the terms that he uses here are just great, and I really like them. So there is, he's got the epiglottis here. It's called the lip of the epiglottis. C is the cushion of the epiglottis. Some people call it the tubercle of the epiglottis. We've got the true vocal cords, which are labeled VC, and then we have the vocal folds, which are, he's calling VB or ventricular bands, but they are the false vocal cords. But down below, these bumps, which we commonly refer to as the arytenoids, was CS, is the capitulum of Santorini, also known as the corniculate, and the cartilage of Riceburg, the cuneiform. But so we've got the cartilage of Riceburg and the capitulum of Santorini, but they were named after the anatomists who first described these prominences that we now commonly call the arytenoids or the posterior cartilages. But this stuff back from the 1800s, and it was drawn from sight because they couldn't photograph it, but pretty cool, I think. And this is an image shot down into the larynx and the hypopharynx after a neck dissection, which involved reflecting all the tissue from across the base of the jaw, pushing that all forward and looking from above. So this kind of laryngeal exposure you're never getting in a real patient because you would have jaw and base of tongue, etc. But it is so neat to look at. And a fellow by the name of Scotty Boliter, who is an EMS guy but also runs an anatomy lab, an incredibly good teacher, he showed me this dissection and I was impressed. So he cut the base of the jaw, reflected all the tissue forward. So what we're looking at here is epiglottis, the hyoepiglottic ligament, the vallecula, which is at that base. We've got the aryepiglottic folds coming down on either side, labeled here. We've got the true vocal cords, which are the vocal ligaments moving as we're speaking. We have the false vocal cord, which I mentioned to you was lateral and above the true cord. And then we've got our posterior cartilages, which we just talked about, cuneiform and corniculate, and we have the interarytenoid notch. Under here is the back wall of the cricoid. So this incision is through the CTM, meaning through the cricothyroid membrane. So above is the thyroid. The front ring of the cricoid is here. That hole is the cricothyroid membrane incised. This is the back of the cricoid. The piriform on either side is a blind sinus that's lateral to the laryngeal inlet, meaning it's outside the aryepiglottic fold. And down here is the esophagus. And we're going to see this better when we do endoscopy. But the other thing that this view really dramatically shows, and I didn't appreciate until I saw this dissection, is this is the left hyoid arm in this patient looking from above, and it goes all the way around to the right. So this whole ring there of the hyoid, it's enormous. It goes from here all the way around at the base of the epiglottis, and it suspends the epiglottis through the hyoepiglottic ligament. But I never knew what that prominence was, and I'm going to show it to you endoscopically. And understanding this 3D anatomy is incredibly helpful, especially when we get to the surgical airway and having confidence at what we're feeling, what we're palpating, where we're cutting. When we look at direct laryngoscopy, here are images that are assembled through my Airway cam, which is this head-mounted camera with an imaging system in front of my dominant pupil. So it is in my line of sight, looking directly at the larynx. And our first structure is the uvula, and it points to the epiglottis. And then the next structure is seen as we manipulate the epiglottis out of view with this indirect elevation of the curved blade is, or rather are, the posterior cartilages and the interarytenoid notch, that little vertical cleft right there. And now we can see it better, posterior structures, interarytenoid notch, a little bit of the glottic opening, which comes into view here. And last and farthest, deepest within the laryngeal inlet is the vocal cords. Now, we're going to next look at this endoscopically as well as with video laryngoscopy. And we're moving a camera now into the mouth, and we're going to get a lot closer to the target. It becomes obviously easier to see. So here's the original black and white glide scope given to me by Jack Pacey when they first developed this. And it was pretty remarkable to get that close to the larynx. And what it shows really well is how this curved blade sitting in the vallecula manipulates the epiglottis out of position, lifts it off of the posterior pharyngeal wall, and as it lifts it up, it exposes the underlying tissue. So this is indirect elevation, but now the video camera is on the blade, obviously, and we've got aryepiglottic fold on either side. We've got posterior structures. Here is the pharyngoepiglottic fold coming up, and there is a hyoid prominence which comes around, and we'll see that actually on the next shot here, but let me point out what we're looking at here. So here's epiglottis. Here's the aryepiglottic fold coming to the posterior structures, which we're looking at here. This is the pharyngoepiglottic fold, so this is going up towards the pharynx, and we're going to take a look at this under some more imaging. But our next view here is of this with a color video laryngoscope. This happens to be the CMAC. The glide scope first came out in black and white, and then it became quickly color. And this is a Macintosh-shaped video laryngoscope blade, the CMAC, in a beautiful sort of case of just great evident landmarks. So here's the uvula. It points to the epiglottis. So that's, you know, and I use that mantra, uvula points to epiglottis. When I'm stressed and the parents are watching me do an intubation on a little kid who's critically ill, and I just kind of want to reassure myself, you know, I say to myself, uvula points to epiglottis. And the reason why I say that, not only is it true, but it guides me to not overrun structures. But I call it progressive visualization. I want to go from one to the next, to the next, to the next. And in my brain, I know that the structures are uvula, epiglottis, epiglottis edge, posterior structures, interarytenoid notch, glottic opening, and cords. Like I'm preparing myself for that progression of landmarks. And by the way, down here is the hyoid. So remember I was telling you how big the hyoid goes all the way around? So that's hyoid. There's hyoid. So this hyoid is way down here, and it is quite large in terms of spanning across the base of the larynx. And then here is that pharyngoepiglottic fold. So that arcing towards the right corner is the pharyngoepiglottic fold on either side. So that takes you from the pharynx to the epiglottis. Here's the hyoid down here. Here's that aryepiglottic fold. Anyway, this is a great view with the true cords. So we're now going to take a look with endoscopy. And this is a friend of mine, Bill Kinkle. We're in New Zealand. Olympus left us a scope lying around during lunch. We licked the scope. Not exactly the most hygienic thing to do, but then we self-scoped ourselves. And so here's Bill moving through the floor of the nasopharynx, along the septum, underneath the inferior turbinate. Posterior is up, anterior is down. No anesthesia needed if you know how to drive. Soft palate of the nasopharynx here. Bill's going to advance the scope slightly further, and then he articulates the tip down. Now we're looking down at epiglottis, and we're going to visualize the larynx. And the cool thing here is we're going to see the structures with voice. So we're going to see the dynamic movement as Bill starts humming and as he starts swallowing and laughing. So here is the esophagus, a potential space that Bill's going to actually burp, and we're going to see it pop open. But here he is, just breathing through the nose and trying to distend his esophagus, which is quite the skill. Here comes a burp. Wait for it. Wait for it. Quite impressive, William. That's where the suds go in Bill's body. Right there. There's the burp.
Maybe your esophageal sphincter being so, pathologic. That's why you get such a reflux.
Watch what happens with phonation.
Look, your larynx doesn't look bad. You haven't had that much lately?
Not at all.
What do you think changed?
Got me.
Sicko, dude.
No.
Sicko. But you got no audio.
I do.
You got audio of this?
Yeah, and you're in my frame now.
This is a younger version of me.
Greetings, Airway fans, live from Auckland, New Zealand. The Airway Olympics.
Where's David going? They're going. Say hi, Paul. Go say hi.
So Paul Baker is a friend of mine from New Zealand. He's been involved with a lot of difficult airway stuff. But yeah, I love these images of Bill laughing with the endoscope in place.
That's very weird. All right, you gotta swallow there. Get rid of some goo.
Yeah.
Good job.
There's another burp.
Wonderfully paid yourself.
Yeah.
Much better than mine. That's great.
The apex of the larynx is down.
Bill, you're a nut.
I could do this
They
for
haven't
hours.
cleaned that for you, have they?
So the apex of the larynx is down. What I mean by that is when you run a scope into yourself and you're looking at a screen, anterior is this direction, and when you're pointing a scope into yourself or you're facing the patient, anterior, the apex of the larynx, the V is pointing here. When we do laryngoscopy, the patient is supine and now the apex is up. So I have reoriented the endoscopic image that Bill just acquired. I've reoriented it now as though the patient were supine, and what we're looking at here is vallecula, posterior pharyngeal wall, glottic opening. The hyoid bone I mentioned to you is that prominence that is around the base of the epiglottis, and it goes way out to the side there, and so we can see that. Here's the cushion, or the epiglottic tubercle. It's a triangular shaped structure that comes to a little prominence there. And I once called an ENT consult because I thought that was a mass. Not a mass. It is the epiglottic tubercle. But here's the false chord. It is lateral and above the true chords. With phonation, the vocal cords come together. The posterior cartilages slam together. The interrytenoid notch during relaxation and respiration is wide open. With phonation, it closes in like so. It turns into this little narrow slit, and then with relaxation, it opens up again. But yeah, that's a great endoscopic view of the airway. So stroboscopy is a mirror pointed down at the larynx with a light strobing to match voice. Look at the movement of the saliva there. Isn't that incredible? And then this is breathing here, just relaxing. Here's the cricoid ring, by the way. So this is how ENT does voice assessment. So light is strobing to match the vibration, so we get a non-distorted view of this dynamically moving structure. And we have here epiglottis at the base. So in this case, the apex of the larynx is down, so anterior is down, posterior is up. And here is some still images capturing that. But the false chord, so this is an incredible way to look at the inner larynx. But here's the false chord. It's a mucosal fold. It's lateral and above the true chords. Here's the cricoid ring, and the epiglottis is down below here, this kind of fuzzy big structure. We're looking straight through the chords at the cricothyroid membrane because remember, this is the cricoid ring, and this is where our incision is. And this is a big deal when we do surgical airway. We're only, a half centimeter, 1 centimeter below the vocal cords. It's right there. So we're looking right at the CTM. And here's with phonation, the cords come together, the interarytenoid notch closes. So you see these big prominences. Look at how widely spaced this prominence is over here and how broad and flat that is here. And then you look over here and it has just come together. So the posterior structures move together. The interarytenoid notch closes into this thin vertical slit and the vocal cords come together. And when we do laryngoscopy, we're going to see with video and direct sort of the effect of upward lift, and that these structures, these posterior structures, they do move during laryngoscopy, but they also move, obviously, during phonation. So the trachea is a corrugated tube, I mentioned, about 10 to 12 centimeters long, has tracheal rings. It has a membranous portion, which is flat and posterior. So anterior is where the rings are, posterior is the membranous section. The esophagus is right behind it. And by the way, people think of things in the esophagus as not causing airway problems, like maybe drooling problems, but they can cause airway problems if the membrane, if you have something that's significantly large and it starts causing protrusion of the esophagus, it can then push from behind and start occluding the airway. So there's case reports, for instance, of a combi tube in the esophagus, but the esophageal balloon is overinflated, causing obstruction of the airway from behind. And this can become an issue with post-op hematomas or significantly large swallowed foreign bodies. If you swallow a marble and it gets stuck in your upper esophagus, it could, from behind, compromise the airway by causing the posterior membranous trachea to bulge into the lumen of the airway. So let's go over some surgical anatomy here just to wrap up this anatomic section. This is a Gray's Anatomy picture of the hyoid, the thyroid, and the cricoid. So the cricoid ring is small in the front. This is the thyroid-cricoid overlap, which we talked about. And here is a male thyroid. You can tell that by the prominence of the thyroid notch, the prominence of the thyroid itself, which comes together in males at 90 degrees and females at 120. We're going to go over this when we discuss the surgical airway. And this is some neck landmarks in a younger man with the thyroid notch, the thyroid prominence, the cricothyroid membrane, the front of the cricoid ring, and the hyoid. And this is this, rhomboid of structures made up of hyoid, thyroid, cricoid down here, and we're going to go over this again when we discuss cutting the neck. A wonderful laryngeal model from Paris, 1835. Louis Thomas Jefferson Azou dug up the dead in Paris, created these papier-mâché models, the first medical models in the world. I bought one of these on eBay. It's such a beautiful piece of art here showing the hyoid. And I mentioned to you the superior cornu of the thyroid. So the top arm of the thyroid comes all the way up to the hyoid. The lower arm of the thyroid goes all the way down and overlaps the cricoid on either side. Here's the small front ring of the cricoid. The back wall of the cricoid comes up to here inside the thyroid lamina. So here's our CTM. I call this space the cartilaginous cage, but that overlap of thyroid and cricoid is important for people doing cricothyroid incisions, namely surgical crikes, to appreciate that this is a hard stop. And that's a good thing, because if you're in the right space, there is a lateral border that you're going to hit, and you don't need to worry about going too far laterally. The other thing is the back wall of the cricoid is very high, and that back wall is protective. You're not going to cut too deep. You're not going to go into the esophagus. If you're at the right level, you do not need to be worried about going too far lateral or too far back. What I say is the cartilaginous cage will protect. But we're going to talk more about that when we get to the surgical airway. But here is this array of structures that I was pointing out before, now delineated here, and on coronal CT, hyoid, thyroid, overlapping cricoid. So I call this the rhomboid. And the mobility of the larynx is protective of the larynx, facilitates voice, but also swallowing. In this young man, we're going to see all of the structures move, but the structures we're looking at, just to point out, here's the thyroid prominence, thyroid notch, so Adam's apple, very large thyroid cartilage here. Here's the cricoid, and it loops around like this. The cricothyroid membrane is marked in X, and here's the tracheal rings. So let's watch as this young man swallows, and you can really appreciate how much mobility there is to his larynx. Pretty neat. The good news about this is it protects the larynx from blunt force, but it requires that when we are doing surgical airway, we have all this mobility here, side to side. The patient, unless they're swallowing, it's not moving up and down, but there is this need to stabilize the larynx in terms of side to side. It's one of the critical aspects of how we do thyroid, how we do surgical airway. So to summarize key anatomic things that I think emergency airway providers should be aware of is, you should understand the sequence of structures, that when we stick in laryngoscopes, we scissor open the mouth, we're looking at uvula, the next thing we see is epiglottis. Under the epiglottis, the next thing we're going to see is posterior cartilages and notch. And then we're going to get a little bit of the glottic opening, and farthest and deepest within is the cords. Like, you should know in your brain that sequence of structures. When you stick in endoscopes, you have to have an awareness of what structures are going to come into view when. I think about this same sort of progression of landmarks and the awareness of landmarks when I do ultrasound. Some people think that the way to teach ultrasound, for instance, is just to let the trainees go and learn as they go and just put probes on and go. I think it's much better for airway as well as ultrasound to look at it done properly on video and or still images and see that sequence and learn the relationship of structures so that when you then drive for the first time yourself, you know the relationship of things. But anyway, getting back to the endoscopy, we stick the scope in. We've got the septum medially. We've got the inferior turbinate. We're going to drive along the floor of the nasopharynx. We're going to exit the nasopharynx. As we exit the nasopharynx, eustachian tube is out lateral. The hard turn to come down, aim low, and you see the soft palate, and then you get the epiglottis, and then you have the person phonate and breathe through their nose, and you'll get a view of the larynx. But you need to have an awareness of these structures if you're going to drive confidently with these instruments. The 3D appreciation of structures, which we can get as emergency providers doing CAT scans, I think is incredibly valuable for surgical airway.